Welcome back, I'm Dr. Elise Martin. At this point in the book, you've seen how autism unfolds across multiple systems: digestion, peptides, immune tone, methylation, neurotransmitters, rhythm, and vagal signaling. You've also seen why no single intervention tells the whole story. Now we return to something practical, and often confusing. Laboratory markers. This chapter is not about turning parents into clinicians, or clinicians into data technicians. It's about learning how to interpret clues without mistaking them for verdicts. Because in complex systems like autism, labs don't give answers. They give orientation. Many families encounter the same paradox. Symptoms are real. Function is clearly affected. But labs come back normal. This doesn't mean nothing is happening. It means the system is compensating. Standard reference ranges are designed to detect disease states: organ failure, acute deficiency, infection. Autism rarely lives in that territory. It lives in the space between normal and broken. That space is where regulation struggles, but collapse hasn't occurred. Labs in autism often reflect adaptation, not pathology. Gut pH is rarely measured directly, yet it quietly shapes nearly everything downstream. Low stomach acid does not always show up on routine tests. Instead, it leaves indirect fingerprints: poor protein digestion, incomplete enzyme activation, altered secretin signaling, shifts in microbial balance. When stool pH trends high, when pancreatic elastase is borderline, or when undigested fats or fibers appear, these are not isolated findings. They suggest the digestive sequence is incomplete. And when digestion is incomplete, peptide load increases. Direct peptide testing is limited and not always accessible, but peptide burden announces itself indirectly. Behavioral changes tied tightly to meals, regression after dietary exposure, food cravings that feel compulsive rather than flexible, neurological symptoms without clear inflammatory markers. When these patterns align with digestive insufficiency or gut inflammation, peptide involvement becomes a strong possibility, even without a positive lab. Peptides are often felt before they are measured. Immune labs in autism often show subtle, confusing patterns: low-grade inflammation, mild cytokine shifts, altered IgA, histamine imbalance. These findings rarely point to a single cause. Instead, they suggest immune uncertainty. The immune system is responding, but not decisively. It is exposed to fragments, mixed signals, and incomplete information. This ambiguity feeds back into somatostatin tone and global signal suppression. The immune system is not attacking. It is hesitating. Methylation is often approached through nutrient levels: B12, folate, homocysteine, but availability does not equal flow. High B12 can coexist with poor intracellular utilization. Normal homocysteine can mask congestion upstream. One of the most informative clues is reaction rather than baseline. If small doses of methyl donors produce outsized responses, irritability, sleep disruption, emotional volatility, this often signals upstream pressure, such as adenosine accumulation or impaired clearance. The system is not deficient, it is congested. Neurotransmitter labs reflect what the system is doing with what it has. They are outputs. Low levels may reflect inadequate precursor supply. High levels may reflect poor receptor signaling or clearance. Without gut and methylation context, neurotransmitter data can mislead. With context, they confirm patterns already visible in behavior and rhythm. They tell us how the system is coping, not what caused the strain. Single data points rarely guide action. Trends provide a view over time and can show fluctuations after intervention, time of day symptom patterns, consistency across lab categories, alignment between labs and lived experience. When digestion improves and labs stabilize, behavior often follows. When labs look better but function worsens, timing or sequence may be off. The most reliable interpretation comes from triangulation. Some of the most important markers are not drawn from blood. They show up in daily life: late afternoon crashes, night waking after progress, mood shifts tied to meals, sensitivity following improvement. These are not subjective impressions, they are system outputs. When tracked consistently, they often reveal bottlenecks before labs ever change. There is a temptation to test everything. But in complex systems, Excess data without integration creates noise. A smaller set of well-chosen labs, interpreted alongside rhythm, behavior, and response to change, often provides clearer guidance than exhaustive panels. The goal is not certainty, it is direction. Labs should inform pacing, not force correction. They help us decide when to proceed, when to pause, when to simplify, when to support recovery rather than activation. When labs are treated as absolute targets, the system often resists. When they are treated as feedback, the system cooperates. This content and other content on this channel is for informational purposes only and should not be considered medical advice, diagnosis, or treatment. Always consult with a healthcare professional before making any changes to your health routines or treatment regimen. As we close this chapter, I want to leave you with a grounding thought. Laboratory markers are not judgments about the body. They are clues about how hard it is working to stay balanced. When we learn to read those clues, alongside behavior, rhythm, and response, intervention becomes less about control and more about collaboration. In the next chapter, we'll look at how these insights evolve across development, especially during puberty and hormonal transitions, and why timing matters even more during periods of change.